Hi, this is Dr. Akhtar and today the topic is bacterial keratitis. The common pathogens are Pseudomonas aeruginosa. It is a ubiquitous gram-negative bacillus or rod. And it is a commensal of the gastrointestinal tract. Pseudomonas infection is typically aggressive and is responsible for over 60% of contact lens keratitis. So Pseudomonas is a gram-negative rod and 60% of contact lens keratitis. Next cause is Staphylococcus. Staphylococcus aureus is a common gram-positive, coagulase positive commensal. It lives in the nerves, it lives in the skin and conjunctiva, and from there it can enter the eye and infect the eye. Keratitis present with a focal, fairly well-defined white or yellow-white infiltrate. The next common organism is Streptococcus, in which Pathogens is a common gram-positive commensal of the throat and vagina. Strep pneumonia is a pneumococcus and is a gram-positive commensal of the upper respiratory tract. Infection with Streptococcus are often aggressive. The bacterial keratitis usually develops only when ocular defenses have been compromised. However, some bacteria including Neisseria gonorrhea, Neisseria meningitis, Corynebacterium, diphtheria and Haemophilus influenza, they are able to penetrate a healthy corneal epithelium, usually in association with severe conjunctivitis. It is important to remember that infections may be polymicrobial, including bacterial and fungal co-infection. Risk factors, the number one is contact lens wear, particularly if extended. It is the most important risk factor. Corneal epithelial compromise, it is secondary to hypoxia, and minor trauma is thought to be important. Bacterial adherence to lens surface is also important. Soft lenses are higher risk than those of wearing rigid case permeable lenses. Infection is more likely if there is poor lens hygiene, but it can also occur even with apparently meticulous lens care, and it can also occur with daily disposable lenses. Next risk factor is trauma, including refractive surgery, particularly LASIK, has been linked to bacterial infection, including with atypical mycobacteria. In developing countries, agriculture injury is the major risk factor when fungal infection should be considered. Next risk factor is ocular surface disease, such as herpetic keratitis, bullous keratopathy, dry eye, chronic blepharitis, trichiasis, entropion exposure, severe allergic eye disease, corneal anesthesia. Other risk factors are local and systemic immunosuppression, diabetes, vitamin A deficiency. So, bacterial corneal ulcer should be excluded in a patient who wear contact lenses and present with painful red eye and blurred vision. Clinical features, there is pain, photophobia, blur vision, mucopurulent discharge. Signs, there is epithelial defect, with infiltrate involving a larger area and significant circumcorneal injection. Here you can see in these pictures. Stromal edema and folds in the decimate membrane, anterior uveitis, commonly with a hypopyon, posterior synecdoche in moderate to severe keratitis, plaque-like keratitis, keratic precipitates. Plaque-like keratic precipitates can form on the endothelium contiguous with the affected stroma. Here you can see stromal edema. Chemosis and eyelid swelling can occur in moderate to severe cases. Severe ulcer may lead to dysmetocele formation and perforation, particularly in Pseudomonas infection. Here you can see scleritis can develop, particularly with severe perilimbal infection. Endophthalmitis is rare in the absence of perforation. Improvement is usually heralded by a reduction in eyelid edema and chemosis, shrinking of the epithelial defect, decreasing infiltrate density, reduction in anterior chamber signs. There is subsequent scarring. It may be severe, including vascularization. In addition to opacification, irregular astigmatism may limit vision. Reduced corneal sensation may suggest associated neurotropic keratopathy, particularly where there is no other major risk factor. Sensation may also be reduced in chronic surface disease, herpetic keratitis, long-term contact lens wear. Intraocular pressure should be monitored. Differential diagnosis. It includes keratitis due to other microorganisms such as fungal keratitis, acanthamoeba keratitis, stromal herpes simplex keratitis, mycobacterial keratitis, marginal keratitis, sterile inflammatory corneal infiltrates associated with contact lens wear, peripheral ulcerative keratitis, and toxic keratitis. Investigations. Number first is corneal scraping. Corneal scraping may not be required for small infiltrate, particularly one without an epithelial defect and away from visual axis. A non-preserved topical anesthetic is instilled. Preservatives may lower bacterial viability for culture. 1 drop of proximetacaine 0.5% is usually sufficient, but tetracaine may have a greater bacteriostatic effect. Scraping are taken either with disposable scalpel blade. Number 11 or Bart Parker. It can also be taken with the bent tip of large diameter like 20-21 gauge hypodermic needle. Or it can also be taken with sterile spatula, for example, Kimura. The easiest way to plate scraping without breaking the gel surface is with a spatula. If a fresh spatula is not available, for each sample and a single instrument should be flame sterilized between scrapes by heating for 5 seconds, cooling for 20 to 30 seconds. Alternatively, a fresh scalpel blade or needle can be used for each pass. Calcium alginate swabs may also be satisfactory. Loose mucus and necrotic tissues. They should be removed from the surface of the ulcer prior to scraping. The margins and base, except if very thin, the margin and base of the lesion are scraped. A thin smear is placed on one or two glass slides for microscopy, including gram stain. A surface is provided on one side of one end of the slide, conventionally up for pencil labeling. Sample is allowed to dry in the air at room temperature for several minutes, then placed in a slide carrier. Rescraping is performed for each medium and samples are plated onto ocular media, taking care not to break the surface of the gel. These are the culture media. The culture media are blood agar. Blood agar is used for most bacteria and fungi except Neisseria, Haemophilus and Moraxella. The blood agar is 5 to 10% sheep or horse blood. Next is chocolate agar. Chocolate agar is used for Fastidious bacteria, particularly H. influenza, Neisseria and Moraxella. Chocolate agar is blood agar in which the cells have been lysed by heating. It does not contain chocolate. The next is suburate dextrose agar. Suburate dextrose agar is used for fungi. It has low pH and antibiotic to deter bacterial growth. It contains chloramphenicol. And there is non-nutrient agar seeded with E. coli used for Acantha amoeba. And this E. coli is a food source for Acantha amoeba. Next is brain heart infusion. It is difficult to culture organisms, particularly suitable for streptococci, meningococci, supports yeast and fungal growth. Brain heart infusion is rich, slightly buffered medium providing a wide range of substrates. Cooked meat broth. Cooked meat broth is used for anaerobic, for example, propine bacterium, acnes as well as fastidious bacteria. Cooked meat broth developed during the First World War for growth of battlefield anaerobes. Levenstein-Jensen medium. Its specificity is against mycobacteria and nocardia. Levenstein-Jensen contains various nutrients together with bacteria growth inhibitors. So routinely blood, chocolate and suburate media are used initially, and the samples are placed in an incubator until transported to the laboratory. Refrigerated media should be gently warmed to room temperature prior to sample application. A blade or needle can be placed directly into the bottled media, such as brain heart infusion. There is evidence that a single scrape sent in brain heart infusion to the laboratory, where it is homogenized and plated, provides similar results to the traditional multi-scrape method. Scraping may be delayed without treatment for 12 hours if antibiotics have previously been commenced. Conjunctival swabs may be worthwhile in addition to corneal scraping, particularly in severe cases, as occasionally an organism may be cultured when a corneal scrape is negative. Cotton wool, calcium alginate, and synthetic swabs have all been found to have some bacteriostatic effect. Calcium alginate may be the best option. Contact lens cases, as well as bottles of solution and lenses themselves, should be obtained when possible and sent to the laboratory for culture. The case should not be cleaned by a patient first. Gram staining. Gram staining differentiates bacterial species into gram positive and gram negative based on the ability of the dye to penetrate the cell wall. So it is based on the crystal violet dye to penetrate the cell wall. The bacteria that take the crystal violet dye, they are gram positive, and those that allow the dye to wash off are gram negative. There are other stains which generally are not requested at initial investigation. These are the stains. The gram stain for bacteria, fungi, microsporidia. Giemsa stain for bacteria, fungi, acanthamoeba and microsporidia. Chalcofluor white fluorescent microscope for acanthamoeba, fungi, microsporidia. Acid fast stain AFP. For example, Zeal, Nielsen, aramine or fluorescent. For Mycobacteria nocardia species. Crocus, Kumuri, methnamine silver for fungi, acanthamoeba and microsporidia. Periodic acid scape PAS for fungi and acanthamoeba. The culture and sensitivity reports should be obtained as soon as possible. The type of bacteria will provide an indication of the antibiotic category to be used. An indication of resistance and the standard sensitivity testing does not necessarily extrapolate to topical antibiotic installation, where very high tissue levels can be achieved. Treatment. General considerations. Hospital admission should be considered for patients who are not likely to comply or patients who are unable to self-administer treatment. Hospital admission should be considered for aggressive disease, particularly if involving an only eye. Discontinuation of contact lens wear is mandatory. A clear plastic eye shield should be worn between eye drop installation if significant thinning or perforation is present. Decision to treat. Intensive treatment may not be required for small infiltrates that are clinically sterile and may be treated by lower frequency topical antibiotic and or steroid and by temporary cessation of contact lens wear. It is important to note that the causative organism cannot be defined reliably from the morphological appearance of the ulcer. Empirical broad spectrum treatment is usually initiated before microscopy results are available. Local therapy. Topical therapy can achieve high tissue concentration and initially should consist of broad spectrum antibiotics that cover most common pathogens. Initially, installation is at hourly interval, day and night, for 24 to 48 hours, and then is tapered according to clinical progress. Antibiotic monotherapy has the major advantage over dual therapy of lower surface toxicity. Antibiotic monotherapy has advantage as well as it has greater convenience. A commercially available fluoroquinolone is the usual choice for empirical monotherapy and appears to be about as effective as dual therapy. Ciprofloxacin, ofloxacin, used in countries where widespread resistance to earlier generation fluoroquinolones has not been identified. Activity against some gram-positive organisms, particularly some streptococci, may be limited. Resistance to fluoroquinolones has been reported in some areas, Staphylococcus species in the USA, Pseudomonas in India, moxifloxacin, gedifloxacin and becifloxacin Their new generation fluoroquinolones largely address this and also have better activity against gram-positive pathogens. Moxifloxacin has superior ocular penetration. Novel drug preparation with a higher concentration or modified vehicles have been introduced to enhance antibacterial activity. Ciprofloxacin instead is associated with white corneal precipitates that may delay epithelial healing. Antibiotic do therapy. It may be preferred as first-line empirical treatment in aggressive disease or if microscopy suggests streptococci or a specific microorganism that may be more effectively treated by a tailored regimen. Empirical do therapy usually involves a combination of two fortified antibiotics, typically a cephalosporin and an aminoglycoside, in order to cover common gram-positive and gram-negative pathogens. Antibiotics are not commercially available and must be specially prepared. A standard parenteral or lyophilized antibiotic preparation is combined with a compatible vehicle such that the antibiotic does not precipitate. Optimally, the constitution should take place in the sterile preparation area pharmaceutical dispensary. Disadvantages of fortified antibiotics include high cost, limited availability, contamination risk, short shelf life, and the need for refrigeration. How fortified antibiotics are prepared? For cephalosporin, cefazolin, cefuroxime, and ceftazidime, 500 mg parenteral antibiotic is diluted with 2.5 ml sterile water and then added to 7.5 ml preservative-free artificial tears. So the concentration will become 50 mg in 1 ml, that is 5%. Shelf life is 24 hours at room temperature, at least 4 days, if refrigerated. For gentamicin, 2 ml parenteral antibiotic is added to 5 ml commercially available gentamicin ophthalmic solution. The concentration is 15 mg per ml. Can be used up to 14 days if refrigerated. Here you can see cephalosporin and gentamicin preparation. Mediatics such as cyclopentolate 1%, homatropine 2%, atropine 1% are used to prevent the formation of posterior synecdoche to reduce pain. Steroids reduce host inflammation, improve comfort, and minimize corneal scarring. However, steroids promote replication of some microorganisms, particularly fungi, herpes simplex, mycobacteria. Steroids are contraindicated if a fungal or mycobacterial agent is suspected. Beware prior refractive surgery and trauma involving vegetation. Steroids suppress inflammation. Steroids also retard the eye response to bacteria, and steroid can be clinically significant, particularly if antibiotic is of limited effect or bacteriostatic rather than bactericidal. The evidence that topical steroids improve the final visual outcome is mainly empirical. The steroids for corneal ulcer trial, SCUT steroid for corneal ulcer trial, found no eventual benefit in most cases, but severe cases counting finger vision or large ulcer involving the central 4 mm of cornea tended to do better. A positive culture result was in inclusion criteria, and steroids were introduced after 48 hours of moxifloxacin. Epithelialization may be retarded by steroids, and they should be avoided if there is significant thinning or delayed epithelial healing. Corneal melting can occasionally be precipitated or worsened. Many authorities do not commence topical steroid until the evidence of clinical improvement is seen with antibiotics alone, typically 24 to 48 hours after starting treatment. Others delay their use at least until the sensitivity of the isolate to antibiotics has been demonstrated, or do not use them at all. The regimens vary from minimal uh, strength preparation at low frequency to dexamethasone 0.1% every 2 hours or prednisolone 0.5 to 1% 4 times daily. Early discontinuation may lead to rebound recurrence of steroid inflammation. Threshold for topical steroid use may be lower in cases of corneal graft infection, as they may reduce the risk of rejection. So, fluoroquinolones eye drops have limited effectivity against gram-positive organisms, particularly Streptococcus. Systemic antibiotics are not usually given but may be appropriate in the following circumstances: for a potential for systemic involvement, when microbiological infectious disease specialists advised should be optimally be sought but should not delay treatment; for N. meningitis, in which early systemic prophylaxis may be life-saving, treatment is usually with intramuscular benzyl penicillin, ceftriaxone, cefotaxime, oral ciprofloxacin. H. influenza infection should be treated with oral amoxicillin with clavulanic acid. And gonorrhea requires a third generation cephalosporin such as ceftriaxone. Severe corneal thinning with threatened or actual perforation required ceprofloxacin for its antibacterial activity, tetracycline such as doxycycline 100 mg twice daily for anticollagenase effect. Scleral involvement may respond to oral and intravenous treatment. Management of apparent treatment failure. It is important not to confuse ongoing failure of reepithelialization with continued infection. Drug toxicity, particularly following frequent instillation of fortified aminoglycoside, may give increased discomfort, redness, discharge despite eradication of infection. If no improvement is evident following 24 to 48 hours of intensive treatment, the antibiotic regimen should be revived, including contact with microbiology laboratory to obtain the latest report. There is no need to change the initial therapy if this has induced a favorable response, even if culture shows resistant organism. If there is still no improvement after 48 hours, suspension of treatment should be considered for 24 hours, rescraping performed with inoculation of broad range media, additional staining techniques requested. Consideration should be given to the possibility of non-bacterial constitutive microorganisms. If cultures remain negative, it may be necessary to perform a corneal biopsy for histology and culture. Excisional keratoplasty, penetrating or deep lamellar keratoplasty may be considered in cases of resistance to medical therapy or for incipient or actual perforation. So, topical drug and preservative toxicity may cause a failure of corneal reepithelialization, which can be confused with persistent infection. For perforation, a small perforation in which infection is controlled may be managed by a bandage contact lens. Tissue glue is often adequate for slightly larger dehiscence. Penetrating keratoplasty or corneal paste graft may be necessary for larger perforations, or in those where infection is extensive or inadequate controlled. Occlusive surface repair techniques may be appropriate in some circumstances, such as in eye with no use of visual potential. Endophthalmitis. No clear protocol exists for the management of endophthalmitis, but a similar approach as post-operative endophthalmitis should be considered, while continuing specific management of corneal infection. Secondary sterile intraocular inflammation should not be mistaken for intraocular infection. Usual rehabilitation. Keratoplasty lamellar may be adequate, may be required for residual dense corneal scarring. Rigid contact lenses required for irregular astigmatism, but are generally only introduced at least 3 months after reepithelialization. Cataract surgery may be required because secondary lens opacity are common, but in the absence of severe corneal opacification, Surgery may be hampered by corneal haze, posterior synechiae, zonular fragility. Thank you so much.